I'm Singh Pallet, the president of CMDA, and Dr. Vikas Reddy, board member with CMDA. We are the co-presenters today for Journal Club. I'm going to cross my fingers that you'll be able to see the screen and see our slides here very shortly. Dr. Reddy, do you want to introduce yourself?
Yes, get my camera on here. Yeah, so my name is Vikas Reddy. Been in the post-acute world for about 7 years. Currently, the vice president of clinical performance and improvement for Summit Medical Consultants, and also proud board member for CMDA.
Yeah. We're proud too. Thank you. Can you see the title slide for the PALTmed Choosing Wisely?
Yes.
Okay, good. All right, well, this is our topic today, and I just wanted to point out that choosing wisely are a group of statements and recommendations that highlight clinical practices that we see routinely, but may not always be helping our patients. So CMDA is the state chapter for PALTmed, the Post-Acute Long-Term Care Medical Association. And PALTmed has been contributing to the Choosing Wisely campaign with recommendations for many years. And earlier this year, 5 new statements were added. I had the privilege of being the chair of PALTmed's clinical practice committee for the past 2 years, and I led a group of clinicians who wrote these recent recommendations. And here's the process. 2 years ago, we surveyed all the various committees at PALTmed and asked people, what do you see commonly in your practice that may not be bringing value to the patients? And from there, we voted on the top 5 that meant that we thought had the most impact, conducted literature searches, wrote out the statements, and consulted experts in the field to make sure they're accurate. Just a few months ago, the board of directors for PALTmed endorsed these statements. So I would say that choosing wisely is consensus-based, but that each recommendation is highly referenced and supported by the literature. Now, this timeline keeps going. We are counting on you to implement the recommendations and have the discussions that apply the most to all of our patients. The Choosing Wisely writers are PALTmed members from all over the country. And before we jump into the statements, I'd like to put in a plug. If you are interested in weighing in on issues for patients in the post-acute and long-term care setting here in Colorado and across the country, you should join PALTmed and you should join CMDA. We need our clinicians' voices. Choosing Wisely statements are all online. All the references are also online, so we didn't include the whole reference list on these slides. And today I'm going to present the 2025 statements, and Dr. Reddy will present the statements that were published prior to 2025. Here's the QR code. They're very easy to find online. The 2025 statements are numbered, numbers 16 through 20. So number 16, don't treat general musculoskeletal pain with muscle relaxants. I think that Dr. Leah Watson taught me that the indication for a muscle relaxant should never be just because the patient has muscles. And sometimes we do see that. All of those medications, the methocarbamol, the cyclobenzaprine, baclofen, they all have a high risk of side effects. Some of them are listed here on the slide. There are some studies that show an efficacy for muscle relaxants in the setting of acute lower back pain or in the perioperative setting. There might be some long-term use for people who have spasticity related to the central nervous system, and even in those cases, long-term benefits may be very limited. So for general musculoskeletal pain, use other modalities. Don't rely on muscle relaxants. Next, don't prescribe iron supplements for more than once a day use. In my chart reviews, I occasionally see medication lists where iron is prescribed BID or TID. The gastroenterologists like to point out that when patients take oral oral iron. The levels of serum hepcidin increase in response and will remain increased for up to 48 hours. And this increase in hepcidin blocks further iron absorption. There's no reason to take iron more than once a day because it will not improve the benefits. It will not improve the absorption, but it will increase the side effects. And we don't need our patients to be constipated all the time. Don't combine multiple medications with anticholinergic activity. In order to follow this one, we need to be aware of which medications have anticholinergic properties. There are several lists that we can use and several tools that we can use to help identify anticholinergic medications. We also need to be prepared with a strategy to minimize the use of anticholinergic medications. And recently, I heard a presentation from the authors of the Beers list where they discussed alternatives to the medications on the Beers list. So as an example, they talked about alternatives to medications that we use for nocturia. So medications that are typically antimuscarinic and anticholinergic. Instead of turning to those medications, let's make sure that we're screening our patients for sleep disorders and other medical conditions. Adjust the fluid intake so we're not having that fluid intake right before bedtime. Watch how much alcohol and caffeine our patients are taking in. Avoid late-day diuretics. Don't forget that SGLT2 inhibitors can have a diuresis effect as well. In the daytime, elevate people's legs when they have edema so that we're not having that nighttime diuresis. Order bladder retraining. Your PT and your OT can be very helpful with bladder symptoms. For the right patient, you might need to turn to a different medication with less anticholinergic activity. Consider mirabegron. For people who have a prostate, tamsulosin, finasteride. If there's vaginal atrophy, maybe vaginal estrogen. Next recommendation, don't use aspirin for primary prevention of atherosclerotic cardiovascular disease in patients aged 70 years and older. The benefits just may not exceed the risk for this situation of primary prevention. And this comes directly from the 2019 guidelines from the American College of Cardiology, where they really looked at the studies. And for older patients who are in the primary prevention stage, aspirin is really not that much better, not at all better than placebo. Finally, don't utilize molecular testing to replace urine culture for diagnosing and determining treatment for urinary tract infection. Now, this recommendation, I am still struggling with it, so let's talk about it for a little bit. A molecular testing, such as PCR for the urine, detects fragments of DNA, even if the DNA comes from a microorganism that is not causing an infection. These tests are so highly sensitive that they potentially lead to the overuse of antibiotics. And with the very high prevalence of asymptomatic bacteriuria in long-term care, it makes the potential for harm especially concerning for our patients. So what do we do? What are the alternatives? 1 year ago at this time, I presented on this topic to this audience, to Journal Club, with the supports of Dr. Beely and Dr. Fitzpatrick. Hello, Dr. Beely. Since then, several articles have been published, including a CMDA position statement, all of them urging caution about the use of molecular testing in UTIs, especially in the nursing home setting. And so these articles are available online. The CMDA statement is on our CMDA website. You can print them out and share them with your communities, especially if the only information they have about urine PCR comes from the laboratory companies themselves. So what can we do instead? How can we help our communities follow the current standards of care for a UTI? In my opinion, the alternative is to turn away from the new fancy testing that has not been proven and could potentially cause harm, and go back to the basics of antimicrobial stewardship. The CDPHE has resources for our facilities on its website, and today I'd like to share 4 of the resources. The tool shown on this slide is the UTI Diagnosis Action Tool. It spells out the published criteria for suspecting a UTI and ordering a urine culture. Using this tool helps us follow guidelines rather than falling back on our old habits. Consistent with the guidelines, this tool specifies orders that patients with suspected UTI should have a urinalysis and culture, and it does not say anything about checking a PCR test. The antibiotic timeout checklist helps us ask key questions after an antibiotic has been started. So it needs to be routinely determined whether the orders for an antibiotic are still appropriate within 48 or 72 hours afterwards. When questions come up about situations where the diagnostic criteria for a UTI have not been met, we should all be prepared with this resource on talking with residents and family members about UTIs. And finally, a guide on antibiotic use in nursing homes summarizes the latest on appropriate diagnosis and treatment regimens for UTI, for respiratory infections, and skin and soft tissue infections. But don't rely on those fast, overly sensitive tests that are not FDA approved and could have potential for harm. Instead, use the antibiotic stewardship evidence and the tools that we already have available to us. Now I'll turn it to Dr. Reddy, who will talk about the Choosing Wisely recommendations that were published before 2025.
Yeah, thank you, Singh.
Oh.
All right, number 1, don't insert percutaneous feeding tubes in individuals with advanced dementia. Instead, offer oral assisted feedings. There has been data where the oral assisted feedings has either maintained or improved weight compared to the percutaneous feeding tubes, especially in their dementia patients. We don't want to provide external devices that increases the risk for infections, or even for them to dislodge it and increase their behaviors, which then could potentially lead to prescribing cascades. Next slide. Number 2, don't use sliding scale insulin for long-term diabetes management for individuals residing in nursing home. Sliding scales is a reactive way of treating hyperglycemia after it has occurred rather than preventing it. It's a good point in regards to, avoid masking of symptoms by utilizing the sliding scale as opposed to kind of treating the underlying disease by better management of scheduled dosing, whether it be just with long-acting versus long-acting with some short-acting, which would coincide with the body's natural production of insulin. Next slide. Don't obtain urine tests until clinical criteria are met. So consistent with the updated guidelines as well, to ensure we're reducing unnecessary antibiotic use. I was talking with Dr. Gam, and he did mention probably around 50 to 70% of antibiotic use is deemed to be unnecessary when looking at the statistics. Next slide. Don't prescribe antipsychotic medications for behavioral and psychological symptoms of dementia in individuals with dementia. This is, especially with the new guidelines that took effect, the state guidelines, important to ensure that we're locating the underlying cause for any behaviors and ensuring that there's no reversible causes that could be there, whether it be management of someone's pain that they're not able to express, or if there is some sort of infection that needs to be, treated, of course, meeting McGreer's or Loeb's criteria prior to doing an investigation. Or one of the main things is looking at what we may perceive as benign medications, but is there an additive effect of multiple benign medications where we could reduce the polypharmacy load for them, and then reducing anticholinergics as well. So only use these for symptoms that severely impact the quality of life or safety for himself or from others, in the lowest dose possible and with frequent reassessments for necessity and efficacy. Next slide. Don't routinely prescribe lipid-lowering medications in individuals with a limited life expectancy. Statins, could increase risk of falls with the side effect of myalgias and arthralgias. And also could reduce cognition as well. So for individuals that have less than 10 years of life expectancy, it's recommended to avoid its use. Next slide. Don't place an indwelling urinary catheter to manage urinary incontinence. This is also, important as well. They only have 3 diagnoses where this would be acceptable, whether it's a neurogenic bladder, neuromuscular dysfunction of the bladder, or obstructive uropathy. Again, using a catheter external device increases the risk for infections and increases the risk of overprescribing antibiotics for presumed UTIs when they have an increased risk of this. Next slide. Don't recommend screening for breast, colorectal, or prostate cancer if the life expectancy is estimated to be less than 10 years. And also kind of going with an individual's goals of care, which is important as well to get an understanding of how they want us to drive, their life decisions. But they'll be looking for these screening tests if they have less than 10 years of life expectancy, can reduce their quality of life for all the further investigations and treatment plans that could result from it. Next slide. Don't obtain a C. diff toxin test to confirm cure if symptoms have resolved. The C. diff toxin testing can stay positive even longer than when symptoms have resolved. So it's better just to assume it has resolved if the symptoms have subsided. Next slide. Don't recommend aggressive or hospital level care for frail individuals without a clear understanding of the individual's goals of care and the possible benefits and burdens. And this is very important. We kind of live in a world where everyone values quality over quantity. So getting an understanding, of the patients or their POA's wishes for themselves or their family members, and honoring those wishes. Sometimes I think we're more scared for ourselves than the patient would be. So having those continual conversations to get the understanding of how they want us to drive their care. Next slide. Don't initiate aggressive antihypertensive treatment in frail individuals over 60 years of age. Frail individuals with hypertension, multiple medical comorbidities, or limited life expectancy use clinical judgment, incorporate preferences of the family or the patient, and evaluate the risk benefit and decide on the medications and the intensity of control. Too tightly controlled blood pressures can lead to also memory decline, and more importantly, the increased risk of falls, which, as we all know, has been highly prevalent in this industry for quite some time. And per the JNCA guidelines, for patients 65 years or above, the goal is to have a blood pressure reading of less than 150/90. But if they have comorbid conditions, then it's less than 140/90. So it's okay to allow for a little bit higher blood pressure readings or even permissible hypertensive levels as well, depending on their goals of care. Next slide. Don't continue hospital prescribed stress ulcer prophylaxis with PPI therapy in the absence of appropriate diagnoses and in the post-acute and long-term care population. PPIs can lead to pneumonias, C. diff, malabsorptive states. So if a patient's able to get off of PPI therapy, that would be the recommendation. Next slide. Don't order routine follow-up chest imaging for post-acute and long-term care residents with community-acquired pneumonia whose symptoms have resolved within 5 to 7 days. That goes along with the test of cure, for C. diff as well. base it off of symptom relief as opposed to assessing for imaging resolution. Next slide. Don't routinely prescribe or continue sedative hypnotics such as Restoril or Ambien, Benadryl, benzos, or serotonin modulators such as trazodone in long-term treatment of sleep disorders in the geriatric population. Consider use of non-pharm interventions such as physical therapy, therapy at a regular schedule, or cognitive behavioral therapy. Especially with the new guidelines in this realm too, this would be considered a harm tag at this point as a chemical restraint with the cutoff of 7 hours of sleep. So recommended to have sleep tracking with the facilities, as well. This also increases the risk of, weight loss, falls, and other adverse events as well. Next slide. Don't routinely prescribe or continue acetylcholinesterase inhibitors or N-methyl-D aspartate antagonists in patients with advanced dementia. Even with the data, it shows the most prime patient to receive these medications would have modest benefits at best. It also reduces or increases the risk of falls, reduced appetite, weight loss, and bradyarrhythmias as well. Next slide. Don't provide long-term opioid therapy for chronic non-cancer pain in the absence of clear and documented benefits to functional status and quality of life. This is pretty big. Dr. Eber did have a great presentation regarding this a few months back as well, in regards to assessing a person's functional status as opposed to a pain scale as a more accurate indication of pain management. Next slide. All right. Now that was a lot in a short amount of time. But does anyone have any questions?
That was one of the writers. Of course, I think the PALTmed statements are awesome and amazing, and everyone should be using them. And as we mentioned, these statements are all consensus-based, and they're backed by literature. You can get them online. You can use this QR code. But we thought we could use the last few minutes of Journal Club just to open it up. Any questions about them? Any comments in general about choosing wisely, or any reflections on how any of the statements have affected you and your patients?
I have a question. This is Dave Shepard.
Sure.
So I've seen as far as sliding scale insulin, I've seen sometimes not a sliding scale, but a PRN for Humalog, 5 units if glucose greater than 300 or something like that. To me, that kind of falls in the same ideology, but I don't know. I wanted everybody else's opinion on it.
Just a more simple scale, right? If the glucose is normal, give nothing. If it's above 300, give something.
Yes, exactly. Yeah.
Sure. And I would, side with you as well in regards to kind of a way to skirt sliding scale, but technically it is still some sort of a sliding scale. So the recommendations, would be to, if it's for a short period of time, like a 14-day stop date, to assess how much that patient actually needs, and then scheduling the appropriate amount of insulin during the day, with the Humalog and
You might want to cache that.
You have a comment, Mary?
No, sorry.
Oh, that's okay.
Yeah, and I'm the same way. If we're using a sliding scale for a couple of weeks to figure out, what the insulin dose is, I think that's appropriate. It's when we leave them on there forever. I think that's the spirit of the recommendation. And I had one other question. So for C. diff testing, of course, there's a PCR test for it, and a lot of people are colonized. So if you're going to use a PCR test, I think the recommendation from the GI Society last I saw was to combine that with the toxin assay as well, because the toxin assay tends to be more concordant with actual active infection. So
That's what I've read as well. In some of the diagnostic stewardship literature, they talk about protocols where if labs could start with the one test, like say PCR, but anytime that it is positive reflex to a toxin testing or maybe even antigen testing, that combined, that is going to give you a more accurate current picture. I think in most cases, our providers are just ordering C. diff. We don't really know which test we're ordering or getting, so the labs have to have a protocol.
Yeah, that's the trick. You don't know until you get it back.
Back to the urinary tract infection guidelines. I keep seeing when I Google it that the sensitivity of McGear's in our population is only 30 or 40%. Does anybody know how that was actually arrived at, number one? And number two, does that have any implication in terms of how we address our patients?
Sure. From my understanding, I think McGreer's is more of like a Monday morning quarterback look back in regards to management. And then the Loeb's criteria, I think it's more indicative of who needs to be appropriately put on antibiotics, and then with like the 72-hour stop or timeout to assess if our initial assessment was accurate, whether we need to stop the antibiotics if everything comes back negative, or if we need to continue or adjust from broad spectrum to more directed antibiotic usage. But how the McGreer's criteria first came about, I am not too sure. I don't know if Dr. Pallett, if you...
I was going to turf it to Dr. Beely if you're still on, Lauren. I don't know if you have more information about sensitivity of the McGear's criteria.
Hi, yeah, I would just say, one of my favorite documents about Loeb versus McGear, I'll put it in the chat. But I would echo Dr. Reddy about at least the UTI action tool is based on Loeb criteria rather than McGear. And part of that is just, given that McGear does rely on things like having lab data back, which we don't necessarily have at the time when we're deciding whether or not to start antibiotics. They're both from around the same time frame. Loeb was 2001 and McGear was revised in 2012. So they've both been around for a while, but yeah, I do think that it makes sense to me that McGear may not always apply to nursing home residents. But I do think that distinction is important between the two, and I'll throw that resource in the chat in case that's helpful.
Yeah, so my understanding is McGear's was actually created for observational studies. So it's more of a research geared criteria. So it is not clinically forward-looking, it's clinically backward-looking. So it's more of a research tool, and that's why Loeb criteria is probably a better tool for us to apply to patients.
And making decisions at the bedside,
Yeah.
different standard than collecting data for surveillance purposes. Yeah. But I think that's an interesting
Yeah.
question that Dr. Weaver brought up. I don't know how they had the gold standard for determining McGear's criteria.
Turns out modified Loeb's is only listed as being 15 to 30% sensitive.
Yeah.
We still have a judgment issue here.
Sure.
I mean, I think the criteria are useful to, if you will, bend the curve toward better antibiotic management. We've all had the situation where we followed this criteria. Patients went septic, went to the hospital, and were treated. It's kind of course, the counter argument to that is even if they went for something else, they got treated for UTI, right? But
Right.
I think the criteria have some weaknesses to them that we need to be aware of when we're making our judgments about our patients.
I would agree. That's fair.
Sure, yeah. I think part of the problem is too, like the colonization of bacteria. Because technically a UTI is some sort of infectious process, but everybody's colonized. So I think in the hospital system, when they get hospitalized, they take the urine, and it obviously is going to grow something, but has there actually been a transfer of that bacteria into tissue to cause infection or not? So it's a tough situation. But yeah, I mean, Everybody's been to that where the family member is upset when your family went septic in the hospital and we didn't do anything about it in the nursing home setting.
Yeah, I would agree with that, Dr. Weaver. I mean, I've kind of oversimplified things. I always look for clinical signs and symptoms first because I feel like a urine culture in long-term care is really not a useful tool. It's about 50-50.
I
So,
actually push my facilities to not even get a UA. I push my facilities to check labs, check
yeah,
frequent vital signs, push fluids, and don't even get a urine until the next day, even if they have the complaint of dysuria. Because how many patients, especially a demented patient, how many of us have never had a brief moment of dysuria and then it's just not necessary? So even in situations where they have dysuria and you slow the roll, you check labs, you push fluids, you monitor vital signs, you tell the family you're going to do all of that. And the next day, the labs come back normal, the dysuria is magically resolved, and you don't even have to get a UA. In my opinion, that's worked really, really well. But that's probably aggressive.
I'm totally on board with that one too, Dr. Horton. I like that idea.
yeah. Well, it turns out what we thought was the easiest diagnosis to make in med school is not so easy in long-term care, right?
I see that too. Yeah.
And I agree with the sleep. The problem with that is I've never seen a facility be successful in offering non-pharmacological interventions regarding sleep. So I think some of these recommendations are great. I just think we're all sitting here agreeing, but I think we need examples of successful implementation, in my opinion. So hopefully one of us can break the code on some of these because and I think a lot of it gets driven by families, which is challenging.
For a while in the facility where I was in, we developed a sleep cart where there was a little cart with sleep aids on there, massage tools, lotions, crossword puzzles, eye masks, earplugs, chamomile tea, all sorts of fun things that the staff thought of and contributed to. And that cart would go around the building towards bedtime to help give people sleep aids rather than medications. And that was enabling for me to be able to get people off of sleep medications because I would remind them that we had this cart available.
Yeah, that's a great idea.
It didn't last forever. Someone had to restock the cart and someone had to push it around. And I think we lost those people.
Uh-oh.
Yeah, getting them to turn off the television and the lights is, I mean, that's a challenge, right? It is hard to get these interventions in place.
Well, that and exercise, which we all agree, right? And so, but I don't see, I don't see a push for trying to get movement, and that would be something that we would do during the day at any point. But
I love the way you're thinking, though. We should talk as a community about solutions, practical interventions that would work. Yeah. Well, thank you everyone for your contributions. This was an excellent journal club, and we look forward to seeing you again next month.
thank you. Very good.